Thank you, everyone, for participating in this year's Medicare Part D training. This is a really important project where we help hundreds of people make sure that they're going to have access to the Medicare prescription drugs that they need. So thank you for participating, for volunteering. We have a pretty substantial amount of information to go over today. So I'm going to go ahead and get started with the training. It's divided into a couple of different segments. And so we're going to take some breaks, sort of short breaks after my segment, after Erica's segments, and we'll be answering questions during those breaks. So that'll let us just get through the materials, but also answer people's questions in a hopefully timely fashion. So Medicare Part D, what do you need to know? Make sure, there we go. We're gonna, in today's training, we're gonna cover the Medicare Part D counseling process, what that looks like. We're gonna provide some background information on Medicare, Medicaid, QMB, the low income subsidy. We're gonna go over how folks can use the Medicare.gov plan finder / plan compare to analyze clients' prescription drug plan options and make sure they are going to be receiving the best care or coverage possible in 2022. And then we'll have some sort of wrap up and next steps at the end, letting you know what to expect next as a participant, as a volunteer participant in this program. So what is Medicare? Well, Medicare is federal health insurance that consists of different parts. So Medicare Part A is hospital insurance that covers inpatient hospital care. Medicare Part B is what we sort of think of as traditional outpatient medical insurance. So that's going to cover things like doctors' offices, specialists, lab visits, that kind of thing. Medicare, generally speaking, especially Part B and Part D, which I'll get to in a minute, have pretty substantial cost sharing built into them. One form that cost sharing takes is a monthly premium for Medicare Part B. That is going to be at least $148.50 per month, depending on someone's income. It could be higher than that. And that is usually withheld directly from someone's Social Security check. And that's going to be important to remember as we get a little bit deeper into the training. Medicare Part C is Medicare Advantage, or essentially a privatized version of Medicare, where a private health insurance company takes over responsibility for providing Medicare Part A and B coverage. In addition, some Medicare Advantage plans also combine A and B coverage with Medicare Part D prescription drug coverage. Historically, we've not been too big, I think, on Medicare Advantage plans. One of the big concerns is that Medicare Advantage has their own network of providers that is often very different from traditional Medicare. And so people who get enrolled in a Medicare Advantage plan may not realize that their primary care doctor or their specialist that they see that they have a good relationship with, although a Medicare provider is not enrolled as a participating provider with that Medicare Advantage plan. Some people recently have been enrolled in Medicare Advantage plans and it's been fine, but it's just something to keep an eye out for. And if you have questions about that, or a client you're working with has questions, please talk to your mentor because we'll be able to provide some additional guidance. And then Medicare Part D are standalone prescription drug benefit plans. So people who have Medicare Part D plans will have that traditional Medicare Part A and B insurance. And we're going to spend most of our time today talking about Medicare Part D, how it works, and how you can help people make sure that they have the best coverage possible. Oops, excuse me. So the Medicare Part D overview. What is Medicare Part D? Medicare Part D is a prescription drug benefit. It takes the form of private prescription drug plans that essentially compete for business. Those plans are different based on the jurisdiction where people live. So in Washington, D.C. for 2022, there will be 28 standalone Part D plans. Of those 28 plans, 6 will be low income subsidy or no premium plans for people who have low income. There's an annual open enrollment, also called the open season, every year from October 15th through December 7th. That is when people are allowed to change their plan if they want to or if they need to. The plans themselves change from year to year. Some plans stop covering medications, others might impose new restrictions. And so it's important for people to check and make sure that the plan they are enrolled in now will be okay for them for next year. And any change that's made during the open season will be effective on January 1st of the following year, so January 1st, 2022. Most people can only change their Medicare Part D plan during this time, subject to a few exceptions, but this is generally when people are allowed to change their plans. There is some overlap with the Affordable Care Act's open enrollment season. You can see those dates in the PowerPoint, but I'm not really going to get into that because we're not really talking about the Affordable Care Act's open enrollment. We're talking about Medicare Part D. To the extent that people have questions about the Affordable Care Act, you can bring it up with your mentor and they can probably give you some referral information or something along those lines. And then there are cost sharing subsidies for low income beneficiaries. And people who are enrolled in cost sharing around Medicare Part D or Medicare generally will have some different rules around enrollment. There are some slightly more permissive rules for changing plans. And one of the main things that the subsidies do is reduce out-of-pocket costs for people who are enrolled in Medicare. So what is the low income subsidy? You'll hear about this a little bit during Medicare Part D season. LIS, low income subsidy, is financial help that is centered around the costs associated, the out-of-pocket cost associated with Medicare Part D. People who are enrolled in the low income subsidy have no premium for their Medicare Part D plan, or at least a reduced premium. There is no Medicare Part D deductible, and there's no donut hole. We're going to talk about all these figures a little bit later in the presentation, what the premium and deductible and donut hole are. But all of that cost sharing is essentially paid for by the low income subsidy. In addition, copays are capped at relatively or comparatively low dollar figure amounts for people. Depending on their income, they will pay either $1.30 or $4 for generic drugs, or they will pay $3.95 or $9.85 for brand name drugs. Some plans will have a $0 copayment for some medications, even if there is technically a copayment allowed for that medication. Some plans just have a $0 copayment for a lot of generic drugs. And then once people hit what's called catastrophic coverage, which is a total cost of prescriptions of $7,050, they will have $0 in co-payments as well. So this is very substantial cost sharing assistance for people who are enrolled in Medicare but are low income. In addition to the low income subsidy, there are other financial assistance programs that people may qualify for if they live in DC and they are low income. So I just sort of explained what the low income subsidy is. But in addition to the low income subsidy, people who live in Washington, DC, basically everyone that we're assisting with this Medicare Part D project should also qualify or be enrolled in a program called the Qualified Medicare Beneficiary Program. You will also hear that referred to as QMB or just QMB. That is a Medicare cost savings program that is broader than the low income subsidy program. It is not focused on just Medicare Part D, but it is focused also on Medicare Part B. So people in Washington, DC who are enrolled in QMB are automatically enrolled in the low income subsidy. They do not have to apply separately. So QMB gets people all of the low income subsidy benefits that I just went over. But in addition to that Part D as in dog cost sharing assistance, QMB also provides cost sharing assistance with their Medicare Part B premium, that $148.50 that I mentioned a couple of slides ago. That is paid for by QMB. It also eliminates the vast majority or even all co-payments and deductibles for Medicare covered services. So when people go see their Medicare doctor, or if they're referred to a specialist that accepts Medicare, QMB should essentially pay for any of the traditional Medicare costs that would otherwise go directly to the Medicare enrollee. There are a few limitations that are really important to remember with QMB though. QMB does not pay for services that are not covered by Medicare. So it is not separate health insurance. All it does is help pay for Medicare covered services. It does not pay for things that Medicare itself is not the primary payer for. In addition, the low-income subsidy and QMB do not pay for medications that are excluded from the Medicare formulary. So anything that's covered by Medicare, it's going to help reduce the cost. But if it's not covered by Medicare, then you can't get it through LIS or QMB. The income limit in DC for the QMB program is about 300% of the federal poverty level, and there is no resource limit. That's one of the most generous, I think, QMB income limits in the country. So again, virtually everyone that you help through this program is going to qualify for QMB. If they are not enrolled in QMB, that is definitely something that you want to bring up with your mentor and talk about, because that's a big red flag, and that's usually a way that we can help people substantially reduce their costs. In addition to QMB, there is also full Medicaid health insurance. Medicaid health insurance is generally more restrictive on income and resources. So it has a 100% income limit for at the federal poverty level, 100% of the federal poverty level. And for a substantial portion of our population, there is also a resource limit of $4,000 for an individual. So it is more difficult to financially qualify for Medicaid. But people who do financially qualify for Medicaid will automatically get the low-income subsidy. They will automatically get QMB. And in addition to that, they will get, additional health insurance through Medicaid. Medicare is the payer of first resort, and Medicaid is the payer of last resort for people who are dually eligible. You may hear that term dual eligibles, which generally refers to people who are in Medicare and Medicaid. But Medicaid does pay for some things that are not covered by Medicare. And two very good examples of that are dental care, and there is a much more robust home health benefit under Medicaid that is not covered under Medicare. So to the extent that people can qualify for Medicaid, they should be enrolled in it, because it provides a lot of this cost sharing assistance that we've been talking about, but it also provides coverage of some additional health services. And it also provides some coverage for drugs that may be excluded by the Medicare formulary. And in the training materials, there is a list of types of medications or medications that are excluded by Medicare. And on that list, a little bit further down, you will see a few different kinds of medications that, even though they're not covered by Medicare, they are in fact covered by Medicaid. And so people can have the cost of those drugs reduced through their Medicaid health insurance if they qualify. And so how do we help people meet their prescription drug needs through this project? There's a few different steps that I'm just going to sort of highlight right now. And then I'm going to turn it over to Erica for to discuss the My Medicare login. And then I'm going to come back and talk about some of this in more detail, but this is kind of just an overview. We want to confirm that people are current in their low-income subsidy, Medicaid, and or QMB enrollment. We can also confirm that their enrollment is in place for 2022. To the extent that people need to create a My Medicare login or password and security question, you can help people do that. The My Medicare login is a relatively new requirement, but it has been in place for a few years. So a lot of folks that you'll be helping will already have a My Medicare login, but there may be some new clients that don't have it yet. So we're going to walk you through how to do that. Step 3 is really kind of the meat, I would say, of the analysis. It's analyzing which Medicare Part D plan will be best for the individual beneficiary for 2022 using the mymedicare.gov plan finder. For many people, the plan they are enrolled in now is going to be fine for 2022, and you can confirm that and give them that peace of mind. For a lot of folks, they will need to change their plan. It is going to get more expensive. It may stop covering a medication. They may be taking a new medication. There may be new restrictions in place. So you will want to help them enroll in a better plan to make sure that their costs are as low as they can be for 2022. And then, I sort of talked about steps 4 and 5. You'll be going over a lot of this with your mentor, but making sure people are in the best plan. And if you, have difficulty finding what looks like a good plan, talking to your mentor, because there are some other ideas that we have about how to, help people in those situations. But that is the end of the first part of my presentation. So I am going to stop sharing my screen, and we'll take a few minutes to answer any questions about that kind of overview before I turn it over to Erica for the next part.
And I don't see any questions in the chat yet, so I'll just move on to the next section, but feel free to, as Andrew said, put questions in, and we'll take a couple of pauses in between our sections to answer anything, and then we'll try and make sure we're leaving some time at the end as well. So thank you, Andrew. Thank you, everyone, for being with us. My name's Erica Duray. I'm an attorney at Whitman Walker, and this is my 8th year doing Part D, so I'm excited to see some folks who are new, and also to see many people who have worked with us on Part D in the past. As Andrew has said, it's very important work. Many of our clients receive a lot of confusing and overwhelming information in the mail, and what you're really doing is bringing them peace of mind and kind of helping them sort through all of the clutter, all of the mailings, the phone calls, the outreach that they're getting, and just helping them focus on what's important and making sure that come January, they'll understand how to get their medications and what those costs will look like. And so through this work, the primary tool, as Andrew mentioned a little bit, that we use is the Medicare Plan Finder tool that's available through the Medicare website. And so to navigate to that, you go to medicare.gov. This address that we include on the slide will take you directly to the Plan Finder. But if you go to medicare.gov, you'll see it's also pretty easy to find. And so a couple of years ago, Medicare updated their system. And so in order to get personalized information, you now have to create a My Medicare account. And so there's generally 2 ways to do the search. You can do either that personalized search, or you can also do what's called a generalized search. Both of those options will allow you to review somebody's Part D options and their costs. And so I'm going to walk through now what creating that account looks like. And then at the end, we'll go through a sample case with the intake that was included and show you what the plan analysis looks like when doing a general search. And so on this main screen, you'll see very prominently in the middle an option to log in or create an account. So many clients return to us year after year. And so usually if we've worked with somebody in the past, we'll have created an account with them already. And so you'll receive that information from your host organization if we do have their login details. And so you can then navigate to this screen and then click on the login and log into the account using the details that you have. If you don't receive login information, you can work with the client and you can create an account for them, and you'll receive additional details about that from the host organization. Generally, clients are giving us permission to create this account by sending us their information. So you can go ahead and use the information that's provided to you by the host organization to try and create this account. So to create the account, essentially it'll ask you a series of questions based on what's in the Medicare system. So what's on somebody's Medicare card. You'll receive from your host organization either a copy of the card or an intake form that'll include all of the information that's on that card. And so you have to enter that exactly as it appears into the Medicare website. The system is very finicky. And so if you have a typo or miss part of somebody's name, it will say that the person couldn't be found. And so you want to make sure that you're double checking the intake form. And if you're running into issues, you can reach out to the host organization. You'll also find, as we note here, that if you're having trouble moving forward, it might be because there's a box hidden somewhere on the page that it wants you to check in order to navigate to the next section. And so you'll enter all of the required information. An email address is optional, but it's not required. And under the fields for email address, there's a box that you can check that indicates that somebody does not have an email address. We recommend checking that box, even if somebody has provided their email, because it will save them from starting to get a lot of spam from Medicare that's confusing for them. If a client later decides that they want to include their email, they can add it in the system. And they can either reach out to us to get their login information, or you can send it to them if they ask you for it when you're working with them. So not including it up front doesn't mean that it can't be added later. So it makes the process a little bit easier. And then after you click next, you'll then be taken into the plan finder. And so if you've been able to log into somebody's account, you'll get their personalized information. So you'll see this box that's in gray that will show what their current coverage is. And so that's their Part D plan that they're currently in for this year. And you should also see a section that talks about the level of extra help that they have. And so that's what Andrew was talking about with regards to the low income subsidy. So generally, extra help and low income subsidy are used interchangeably. There's a little bit of difference in terms of the application somebody may have to submit, but in terms of the coverage, if somebody has full extra help, as you can see, that means they have a full low income subsidy and they're able to enroll into a Part D plan with no premium. If somebody is in a Part D plan that is ending, that's being discontinued, for example, you may also see on this screen something that says future coverage and will list the Part D plan that they're going to be in for next year. And this is one of the most important things that happen during Part D is that, as Andrew mentioned, plans do change from year to year. And so, for example, next year, there are actually 2 Part D plans that are being discontinued entirely. And there's one plan that's having a cost change. So that plan will no longer be a 0 premium plan. And so many folks will automatically be enrolled into something else, but they may be getting mail about that and not understanding what that means. People often think it means they're losing their coverage entirely. In some cases, folks are getting automatically switched to a plan that's not a good option for them, or they may not be getting switched at all and may be getting stuck into a plan that's no longer a good option for them. So it's important to review the current coverage, and if there's future coverage that's different, to make sure you're talking about that with the client so they understand if their plan is changing. And I'll go into more detail about all of that analysis at the end of the presentation, and I'll go into the actual Plan Finder website to show you what these things look like. And then under what type of, and this will say 2022 when you go into it, but under what type of coverage, you should always select Drug Plan Part D. As we talked about, Medicare Advantage plans, which are also called Part C plans, are generally not recommended for most of our clients because they can limit their provider network and cause some other issues. We have many folks who are now ending up enrolled into Part C plans because of some pretty aggressive marketing by those plans. And so you'll get guidance from your host organization if a client is in a Part C plan, so that you can talk through that with them and just confirm if it's actually the best option, or if maybe you want to help them enroll into a Part D plan come January. And the process for enrolling and disenrolling from a Part C plan is exactly the same as with a Part D coverage. And I can show you what that looks like on the website later, but essentially, if somebody is in a Part C plan and you enroll them into a Part D plan, it will disenroll them usually from that Part C plan. And that works vice versa as well. And so generally though, when you're going in for this analysis, you'll be selecting that you're doing a review of the Part D drug plan. And then it asks you to enter the zip code. It's important, this question will not pop up. I apologize. This will automatically fill in with the client's current zip code if you're doing the personalized search. If you're doing a generalized search, you'll have to enter the client zip code. And it's important that you enter the zip code that exactly matches their address, because that will auto-populate if you do need to enroll somebody, and you'll have to navigate back through some screens if you need to change it. So as I mentioned, if you're not able to create an account for somebody, you can still proceed with what's called a generalized search. And I did see a question, and I'll just answer that very quickly about whether there's any need to worry about Medigap policies. So Medigap policies are essentially wraparound coverage for Medicare. So they kind of fill in the gaps of what's not covered by Medicare. It is a separate policy that you have to buy through a private company. And it's completely separate from somebody's Part D coverage. So someone's prescription drug coverage is in no way impacted by whether they have a Medigap plan. That just covers the gaps from Part A and Part B. So during this time, we're not really providing any guidance around Medigap. And if folks have questions about that, you can refer them through your mentor and they can get some counseling. And then I saw there was a question about whether periods after middle initial are required. They are not, and middle name is generally not required at all, so you don't need to enter it. What's important is making sure that you enter the exact first name and last name. And I'll have some examples of this in the next section as well. And so for here, just kind of disregard drug plan and Medigap policy and all of these other fields other than drug plan Part D. And so with the generalized search, once you get into it, and I'll show you what that looks like, it mimics the personalized search. So you can still see all of the information about the plans on the website. You see the same costs and coverage options and have the same options around enrollment. It just doesn't automatically populate some of the information in the same way that the personalized search does. With a personalized search, it will usually automatically pull in prescriptions that somebody has recently filled, or if they've entered a medication list in the past, that will automatically populate. With a generalized search, you will have to enter their medications, and we'll go through what that looks like. But if you're running into any issues logging in or creating an account, I would just go ahead and switch to that general search because it is essentially just as good as the personalized search. And so I think I covered this. You would select, the option you select is to continue without logging in to do the generalized search. And then similar to what we saw previously, you select drug plan Part D, and then you'll actually have to enter the person's zip code. And then the difference with the generalized search is that unlike in that previous screen where we saw that it showed us what level of extra help or low income subsidy someone had, for the generalized search, you have to make some selections in order to generate that information. And so the screen where you do that is where it asks you if you get help with your costs from one of these programs. And these are the programs that Andrew was mentioning briefly earlier. So Medicaid and the Medicare Savings Program are those state-based programs that provide additional financial assistance for folks. Supplemental security income is a type of benefit that somebody may receive from Social Security for folks who are low income and low resource. And this information should be provided to you usually by your host organization. You can also check with the client and ask them, do you get Medicaid? Or most folks will understand a Medicare Savings Program as QMB. The other thing you can ask people if they're not sure is money coming out of your Social Security payment? If money's not coming out, as Andrew mentioned, QMB covers somebody's Part B premiums. So if that money's not coming out of their check, then generally that means that they have a QMB benefit, which is the Medicare Savings Program. If you're not sure, then check with your mentor rather than selecting this I'm not sure option. If you select I'm not sure or I don't get help, then it'll basically show you the plans with the full costs. And Andrew will talk a little bit about what those costs look like, but they're significantly higher than what most of our clients pay. So it is important to try and accurately capture this. So if it's not clearly reflected on the intake form and the client's not sure, then just double check with your mentor. And for every case, you will be connected with a mentor from the host organization who can answer questions like this as they come up. But we do try and capture that information before we're sending the case to you so that you can easily navigate through these fields. And then I'm going to pause here and stop sharing. And apologies. And I think, oh, go ahead, Andrew.
Yeah, I was just going to say, we have one question about if we need to help create a new login, does the client agree ahead of time that they are comfortable with sharing their password and security question with the volunteer? And so, yes, we have, I think it's correct for Whitman Walker, but we have a release form whereby clients are essentially consenting to us creating that password, helping them create that password. And then, you know, our standard practice is essentially just to keep it, because our anticipation is that we're going to be helping them the following year and for years to come. And it's good for us to have that so that we can do the analysis that much more easily in subsequent years. But yes, we have them sign a release so they know that they're consenting to us helping them create that password and security question and whatnot.
Just to with Whitman Walker, we also, it's integrated on our form where folks will sign agreeing that we can create this account. Occasionally you'll get something that pops up saying someone already has an account or it's already created and we didn't provide you the information. Sometimes folks have created the account on their own. So you can check with the client if they're able to give you their login information. Sometimes people have created the account and don't remember their login information. So you can ask if it's okay if you try and reset it, or like I said, just go ahead and do that generalized search.
So maybe just give it another few seconds to make sure that folks don't have any other questions at this point.
So yes, so for Whitman Walker, and I assume the same for legal aid, we have a template form that we ask you to fill out when you create the account for folks, and send that information back to your mentor with the other information about the plans that we'll go through. And that way we then save it in our system. So if that client comes back to us next year, we have it. And so usually we ask that you put it on a separate sheet that we provide. I don't know if legal aid does the same, but as long as you communicate it to your mentor in some way, then that way we can save it in our system.
And it's essentially the same for legal aid. That's going to be captured in the intake form. There's going to be a space to write down what that information is, and then that'll be part of the information that you send back to your mentor that we keep for our records. Okay, so at this point, I think the plan is I'm just going to go ahead into my next portion of the presentation. So I will do that. And I'm going to have to get caught up to my next slide, so folks will bear with me. Okay. Oops. Okay. So Erica was just explaining how there are these substantial cost sharing burdens that are built into the Medicare Part D program for people who do not have any of the cost sharing assistance through QMB, the low income subsidy, et cetera. So we're just going to review that so that people know what they're looking at. And if you see these higher numbers at any point in the analysis, that'll be sort of a telltale sign that someone may not have the cost sharing assistance that they likely qualify for. But for 2022, well, for any year, any Medicare Part D plan has a monthly premium. Those range from about $7 to over $100 per plan for the year of 2022. The benchmark is $36.96 per. I'm sorry, $36.96 is essentially what's called the benchmark, which is the figure that's used to determine which plans are low income subsidy and which plans are not low income subsidy. So essentially, when someone is enrolled in the low income subsidy or QMB, in the case of DC residents, the that benefit pays up to $36.96 of the monthly premium for that individual. So there may be plans, for example, that have like a $46 premium. And in some situations, you may encounter that a plan with a hopefully relatively small premium might be the best overall option for that client. So in that situation, you should see a premium of about $10 because it would be the difference between the benchmark amount and then what the plan actually charges. So people who are enrolled in a low income subsidy plan means that the monthly premium is at or below that $36.96, which effectively zeroes it out for someone who is enrolled in the low income subsidy and QMB. In addition to the monthly premiums, there is a deductible that people typically have to pay, which is $485. The enrollee pays 100% of that first $485. And then there are these different coverage periods that come into play based on the total cost of medication for that person to date in the year. So after the deductible, there's an initial coverage period. That coverage period is from total costs of $485 up to $4,430. These amounts change a little bit based on the year, but this should be the amount for 2022. While people are in the initial coverage period, the enrollee will pay 25% of the cost and the prescription drug plan will pay 75%. And given the amounts that we're talking about, it is not hard to see how this can get very expensive very quickly. Once costs go between $4,430 and $7,050, in the past, this is what was called the donut hole. This was a period in coverage where people would essentially have to pay something like 90 or 95%, if I remember correctly, the cost of their medication. I believe the donut hole was closed. It has been closed. I believe the mechanism that closed the donut hole was the Affordable Care Act. But it is not fully closed. There are still cost sharing built into this level, and people get a 75% discount on the full cost of their name brand and generic drugs. So people are still having to pay out of pocket in what was this former coverage gap. Once costs rise above $7,050 for the year, they enter what's called catastrophic coverage. And that is a more generous cost sharing assistance from the plan to the individual. Beneficiaries will pay either a 5% coinsurance on their medication, or they will pay $9.85 for a brain NAM drug and $3.95 for a generic drug, whichever is higher between the 5% coinsurance or those capped amounts. So again, this should not come into play for our clients because they should be enrolled in the low income subsidy and QMB, but it is important to see how expensive this cost sharing can be if people have a problem with their cost sharing assistance. So this is why we want to double check and make sure that everyone is enrolled in the programs that they should be enrolled in. So this is not quite a new rule. It's been in place for a couple of seasons, but for people who've been doing this for a while, it is a change from what they were used to in the past. It used to be the case that anyone who was enrolled in the low income subsidy was allowed to change their Part D plan every month. And that change would be effective on the first of the following month. So they could change their plan in May, it would be effective on June 1st. They could change their plan in August, it would be effective on September 1st. Yes, September comes after August. In 2019, that rule changed though. And there are still more permissive rules around changing plans than just the open season, but it is more restrictive than it used to be. Now people who are enrolled in the low income subsidy / QMB are allowed to change their plan only once per quarter. And that change still goes into effect the first of the following month. So people can only change their plan once from January 1st through March 31st. So if they change it in February, it's effective March 1st. If they change it in March, it's effective on April 1st, but they can only do it one time in those first 3 quarters. Then in the 4th quarter, they are limited to changing their plan to the open season, and that change becomes effective on the first of January 1st of the following year. So it used to be the case that there was a little bit more leeway, particularly during this time of year. I mean, I remember a handful of times when I was making sure someone was enrolled in their correct plan on December 31st of the year, and that is not an option anymore. Now we are limited to this open season. So it is really important to get this done during the open season, because if someone tries to change their plan, let's say in example number 2, on December 20th, it may look to you as you're in the Medicare Plan Finder and you're doing the enrollment and all of that, it may look like it goes through, but Medicare is going to catch the fact that it is after the open season. They are not allowed to make that change at that time, and so it will not go through. That person will have to wait until January to change their plan, and that change will only be effective February 1st. So there is the possibility that people could not be getting the medications that they need for January, if the plan change is not done in the open season. Oops, sorry about that. And so I'm going to talk a little bit about the counseling process and the different steps that we actually take when counseling someone in their Medicare Part D, as part of this project. The first is we want to emphasize, for the reasons that I just said, all of the cost sharing that is built in. We want to emphasize the importance of the low-income programs and enrollment. We want to make sure that the low-income subsidy and QMB and or Medicaid for people who qualify for Medicaid are in place. And Erica mentioned this a few minutes ago, but there are some sort of telltale signs to look for or to ask clients about to see if their cost sharing is in place. The first is to ask if that money is coming out of their Social Security check, because if it is, that is a big red flag that there's probably something wrong with their QMB, and we can help them get that fixed. Second is if a person is paying more than that maximum copay amount of $9.85 for a name brand drug. If they're paying more than that, or if they're paying an amount that's different than those capped copayment amounts that we showed you earlier in the slideshow, it is possible that they are having trouble with their low-income subsidy or their QMB. There may be a handful of situations where someone's paying more and that's okay. For example, if it's a non-Medicare covered drug and there's no other mechanism for them to get cost sharing with that drug, it might be that their LIS and QMB are okay, even if they're paying a little bit more, but that's still something that you really want to pay attention to and talk to your mentor if someone is paying a lot of money out of pocket for any medication that they need. In addition to making sure that their low-income subsidy and QMB are okay now, we want to make sure that they are all set for 2022. As a result of the federal public health emergency, people in DC and I think anywhere should not be losing their QMB and their Medicaid coverage right now. Those have been auto-extended. That said, we do anticipate that the federal public health emergency is going to end at some point in 2022. I think it's scheduled to end right now in January, and there's going to be some sort of grace period. But we do anticipate that this will end at some point in 2022. So we want to make sure that people are still set to have the cost sharing assistance that they need for next year. This deeming of LIS status, again, this is usually more important in years when there's not a federal public health emergency in place that protects people from losing their coverage, but I want to go through it because it is important to understand how this works. If someone is enrolled in QMB or Medicaid in July of any given year or after, so in this case, in July of 2021, that low-income subsidy is deemed to them for the entirety of the following year, even if they lose their QMB or their Medicaid. It's important to remember that QMB and Medicaid are not administered by Medicare or Social Security, they're administered locally. So if someone, doesn't recertify or somehow loses their eligibility for QMB or Medicaid, that happens. That can happen. We help people, get their health insurance fixed on a pretty regular basis. But as long as they have that insurance in place in July of any given year or after, then the low income subsidy that Medicare Part D specific cost sharing benefit will be deemed to them for the entirety of the following year. And so that'll be also something that you can check, assuming you're able to do a personalized search, which Erica was talking about a little bit. She mentioned that you will hopefully see that someone's future subsidy is in place as well. Additionally, if someone is enrolled in QMB or Medicaid at any time in any given calendar year, then they are at least enrolled for the rest of that calendar year in the low income subsidy. So someone who's enrolled in QMB or Medicaid, let's say in March of 2021, their low income subsidy should be in place for the rest of 2021. It doesn't necessarily cover them for 2022. They have to be enrolled July or later for that to carry over, but they should be enrolled at least for the rest of their calendar year if they have QMB or Medicaid at any time during the year. I know that gets a little bit complicated, but rest assured, if you have any questions about someone's cost sharing benefit, please talk to your mentor at Whitman Walker or Legal Aid. That's why we're here, and we can absolutely help you understand what's going on if you are confused, or if someone's paying too much, if they're having money withheld, or if you at any point just find that you're confused about what someone's cost sharing assistance is. So reviewing plan coverage for 2022 using Medicare.gov. Erica walked through how to create the Medicare login and password, or to conduct a generalized search if you have problems creating a login, or if the login that exists is simply not working for someone. I'm not going to go into too much detail on that to avoid being repetitive. You want to review the intake form that you will fill out with people. You want to make sure that you have all of the information that we need. You can reach out to the client, obviously, or to the mentor if information is missing. You know, again, like a client may not remember their own password, but it's likely that Whitman Walker or Legal Aid will have that. So if that's not on the intake form, if your client is not able to remember that, we can help you get some of that information. But you want to ask about their low income subsidy status. You want to make sure that they're enrolled in either Medicaid or QMB if they've been having any trouble. You'll be making sure that you get their full medication list. You know, I like to remind people to just write down the entire full name of the medication. Sometimes medications are combined. You know, write down any letters that come after the name of the medication on the pill bottle. You want to write down the dosage. You want to write down how many doses people take per day. You want to write down if it's a capsule or a tablet when you're choosing a medication in the plan finder. And I know that Erica is going to go over some of this, but it's good to repeat. You know, sometimes you will have to choose the exact same dosage in a in a capsule or tablet form. So just writing down all the information about individual medications that you can will make your life a lot easier later as you're doing the analysis. You want to make sure you know which pharmacy that the client is using, what is their preferred pharmacy, and you want to know what their current Part D coverage is. Again, when you log in, especially to the personalized search, you should see what information Medicare has, but you also want to ask the client to make sure that you know what their current Part D coverage is, because that's what you're going to be comparing to other options for the following year. Will the client's plan still exist and be a zero premium plan in 2022? Or are they going to be automatically switched to a new plan? Erica talked about this. There are a couple of plans that are just going to be discontinued altogether. They're not going to be an option for next year. Express Scripts Value is one of those plans. WellCare RX Saver is another. People who are enrolled in Express Scripts should automatically be re-enrolled in another plan. I think Cigna Secure is the plan for them. And then AARP Medicare RX Select is a plan that I think a fair number of people were enrolled in this year. It is still going to be around, but it's not going to be a zero premium plan. They're going to be about $3.70 above that benchmark of $36.96 that I talked about. So that means that if people stay in that AARP Medicare RX Saver plan, they will have a monthly premium of about $3.70. Some clients will be fine with that. They'll be able to manage that. Others, it might be enough for them to want to change. So that's just something to keep an eye on. And then, you know, like we mentioned, if someone is enrolled in a Medicare Advantage plan, It would be good to get some information about how that happened. They are, as Erica said, marketed very aggressively. These marketers often talk about, what might be a benefit of the plan without going through how it might impact other aspects of their healthcare. And you definitely want to know if the client is having problems. If someone is enrolled in a Medicare Advantage plan, which I sort of mentioned earlier, the main problem that we see, which is a very serious problem, is people not being able to go see the doctors that they want, having their traditional sources of medical coverage or care be not in the network for that Medicare Advantage plan. And sometimes people won't exactly know why they're having trouble seeing the doctors that they want to see. So if they're having any trouble at all, seeing their doctors, getting their health care, and they're in a Medicare Advantage plan, please talk to your mentor, because we'll be able to talk to you about how to advise that person properly. In terms of the next step is going to be sort of reviewing the coverage for the following year. You'll want to review the plan details, keeping in mind that, as a very general matter, nobody likes change. People would prefer to stay in their same plan if they can. Changing plans, it can be a hassle. People are going to get new cards in the mail. They'll have to update their pharmacy with their new coverage. It should, at the end of the day, if someone is going to save a lot of money, then that is worth doing. But it is a little bit of a pain for people to have to deal with a change in plan. So to the extent possible, if you're talking about like a small price difference or something like that, people very well may decide just to stay in their current plan, and that's totally fine. Factors to consider as you're advising someone, what is going to be their best option? Obviously, a key part is going to be out-of-pocket costs, the monthly premiums, if there are any, added up to the co-payments. So again, the AARP Medicare RX Saver, that's a good example. People who are enrolled in that, they may decide that they're okay paying that $3.70 per month if all of their medications are still covered. If any restrictions that are in place, they have those restrictions taken care of. They may decide that it's just not worth the hassle to switch a plan simply to save $3.70 per month. You'll want to make sure that the client's current and future drug needs are going to be covered by either their current plan or a plan that you're recommending. Sometimes you'll see future drug needs. Sometimes, obviously, you can't predict everyone's future drug needs, but sometimes people take medications sort of on a irregular basis. They may know that there's a certain antibiotic or something like that that they have to take from time to time. So even if there's a medication that someone is not taking right now, they may ask that you include it in their drug list and include it in the analysis to be sure that it will be covered if they need it. If there are non-Medicare covered drugs, any drugs that are simply excluded from all of the Medicare plans, you can see, is there a generic version of the drug that's covered? We also have in the training materials, which I mentioned earlier, a memo about specific types of medications that are not covered and options for getting at least some cost sharing assistance with those. Some of them may be covered by Medicaid. Some of them may be covered by ADAP, the AIDS Drug Assistance Program in DC. People may be getting cost sharing assistance through a pharmaceutical company or something along those lines. You'll want to review what the drug restrictions are, quantity limits, prior authorizations, step therapies that are attached to any of the medications that people take. You can click on the plan details, and Erica's going to walk through this with the online protocol, but essentially clicking on plan details for each plan that you're considering will let you look at all of this information for each individual plan and assess whether it's going to be a good fit or whether there are barriers to that person getting the medical coverage that they're going to need. You'll want to consider the pharmacy preference, making sure that the pharmacy that people use are in network with their current plan or with any plan that you're considering referring them to for 2022. Something else you're going to see as you do the individualized search or even the generalized search is going to be a star rating for each individual plan. The star rating by itself is usually not a deciding factor in deciding whether someone should switch or not. It doesn't really impact clients all of that much. So, if someone sees, that there's like a plan with a 0.5-star lower rating, but it still seems like a good fit. At the end of the day, that'll probably still be a good recommendation for someone. So the next step in terms of counseling enrollment is going to be advice and then possible enrollment in a new plan. Always check with your mentor after you have conducted your analysis. Once you have the information from the client, you've gone through, you've gotten all their drugs and all of that. Once you've done the analysis, you've compared their current plan to possible other plans for 2022. At that point, you want to stop, you want to save all of the information, and you want to check with your mentor and go over what your recommendation is. You can print and save plan details as PDFs. That's, especially as we're all working remotely, that's a really good way to save the information. You can email it to your mentor so that you can both be looking at all the same information as you're talking to your mentor about what your recommendation is. You can highlight any concerns related to the low income subsidy, Medicaid, QMB. If someone's enrolled in Medicare Advantage and you have any questions about that, that's a really good time to talk to your mentor and go through all of those questions. After you speak with your mentor, you'll discuss the options with the client. So, you've talked to your mentor, you sort of have a set recommendation. Okay, this plan is going to be fine for them next year. They don't need to switch. Or we've talked, this plan doesn't look good. The costs are going to go up. Here's another plan that I recommend. After you've come up with that recommendation, you'll discuss those options with the client. It's important to remember that changing plans is ultimately going to be the client's choice. You're making a recommendation. Very, very commonly, the client is going to want to follow your recommendation, in particular, when you're talking about really big differences in out-of-pocket costs. But it is important to remember that it is ultimately the client's plan, the client's decision about how they want to proceed for the following year. If you're not recommending a plan change, then if everyone agrees that the current plan is going to be fine for next year, then that's essentially all you need to do. You should inform the client that they'll be fine for next year, but you don't need to do anything. People will default into the plans that they are currently in, unless one of the exceptions arises, the plan's going away or something like that. But assuming the plan that people have for 2021 is still going to be an option for 2022, then if people do not take any action, they will simply default into that plan for next year. You can check with your mentor again on executing the client's preferred course of action if that is different than what you talked about previously. Given the new restrictions on changing plans, again, and I sort of highlighted this earlier, but given the new restrictions, it really is important to check with your mentor before doing an enrollment or before making that final recommendation, because we just want to make sure that people are in the best position possible for next year, and the opportunity to change that runs out at the end of the open season. And then you'll document the steps that you took. If there's any follow-up needed with the client, you can conduct that follow-up after debriefing with your mentor. So step number 5, what if you're in a situation where it appears that there is not a great option? If someone's current plan doesn't look like it's going to be a good fit for them next year, and you're having trouble finding a plan that looks like it's going to be all that much better, particularly from a cost perspective. There are some tips, at this point, obviously, talk to your mentor. That's a very good opportunity to reach out. We're going to have some ideas based on the specific issue that you're facing. Some sort of general troubleshooting tips. Are you including an excluded drug in the search? Someone may just give you their whole list of prescriptions, but one of those prescriptions, it may have nothing to do with Medicare. They may be getting it through Medicaid or some other way. So if that drug is included, that's going to throw off the overall cost. So, double check the drug list, make sure that you're only including Medicare covered drugs. Sometimes people refer to medications by their brand name when in fact they are taking the generic name, and you will have an option to put brand or generic versions of medications into Medicare into the plan finder. So you can confirm with people that if it looks like they're taking a name brand, and if that name brand drug is really pushing the costs up. In fact, if they're taking a generic medication, you can put in the generic medication. That will solve a fair number of problems. I mean, that's something that I encounter, every year, and have to go back and fix usually. is there a pharmacy network issue? Is the pharmacy that the person is using not a network pharmacy with the plans that you're looking at? If you sort of go through some of these, or you talk to your mentor, you go through some other options, if there is no plan that is going to cover a particular medication, then you can just exclude that, and you can run your analysis based on the medications that will be covered. And then you can talk to your mentor about maybe some other options to discuss with the client. At that point, if there is a medication that someone really needs, that it appears that there's no way to get it through Medicare, they can have a conversation with their doctor at that point about trying an alternative medication, something that might, address the same medical issue that may be covered by Medicare. There's a couple of tricks in terms of like specific medications, in terms of inhalers, for example. Many patients are prescribed albuterol sulfate, but you should enter Ventolin, because that's usually going to be how most of the plans cover the medication. That's going to be the way to make sure that you're including the right version of it. And again, just talk to your mentor at that point if you really feel like you've hit a brick wall, or you just, there's one medication that you're just not finding anything good for, because there might be some other options based on what that medication is that would be helpful. And finally, in years past, we did in-person clinics to help people with their Part D. With COVID, of course, last year this was remote. We're doing it remotely again this year. And just a few remote work tips. Try to be as paperless as possible instead of printing things out. Save materials, plan summaries, and all of that as PDFs. That's a good way to, again, email with your mentor. That can be a good way to facilitate the mentoring. Ask clients if they prefer to receive information by email or mail. Some clients may prefer not to receive a copy of the plan details, especially if they're not changing plans. They may just be fine with that. So you could avoid, printing and sending materials or emailing them that way. Remember, like all of us, I think everyone's getting a annoying number of spam calls these days. Clients may be reluctant to answer calls from numbers that they don't recognize. If they have an email address, you can try reaching out by email. If you do get someone on the phone, and this is the first time that you're talking to them, be sure to say that you're working with Legal Aid or Whitman Walker to talk to them about their Medicare Part D, because a lot of folks will recognize that this is something that we help them with every year, and they'll feel more comfortable knowing that you're calling as part of this project. And then just like, sort of basic security measures, try to not store things on thumb drives or USB drives, remove, anything that can be stolen or taken away. That's going to be people's personal data. If you store information on your local computer, try to keep it siloed in a separate dedicated folder that'll allow you to just delete it once everything is done. Once you've sent the information back to your legal aid mentor, you've sent closing letters, then you don't maintain anybody's personal information. So that is the end, I believe, of my second part. So we'll stop sharing, and I see that looks like maybe there were some questions in the Q&A.
Yeah, so I think the first question was, how long does it take to correct QMB if someone's having money taken out of the Social Security check, and if that could delay the ability to do an enrollment? So anyone, regardless of whether they have a low income subsidy or not, can make changes to their plans during the open enrollment season. Depending on what the issue is with QMB, it can take several weeks to fix, but you can still do the analysis. And if the client needs to change plans, they can still do so. And your mentor, depending on the particular situation, may provide some guidance on either doing a generalized search instead of a personalized search if Medicare is not reflecting the correct information, or talk with you about working with the client to do what we can do now. And then we will sometimes kind of hold on to a small subset of cases if there's some lingering issue that hasn't been resolved yet. And then internally we'll make sure that, for example, the QMB piece gets fixed. But you can usually still do the Part D analysis and make any changes that are needed to the plan if somebody does need to change.
And I think it's repeating part of what Erica said, but how easy it is to get that fixed also just depends on what's wrong. Sometimes people may need to apply from the beginning, but other times, we have contacts at the Economic Security Administration and whatnot. So if there's a mistake that's causing someone to not have active Medicaid or QMD, we can help them get that fixed, sometimes relatively quickly, and even perhaps in some cases retroactively if people had gone without it for a while. And then I see another question, since we are not doing this at on-site clinics, would actually signing the clients occur after we get a chance for a debrief? If for some reason debriefing doesn't occur right then, does that mean we call the client again to actually sign them on to their benefits coverage? So this is part of what Erica is going to go through with the online protocol. But yeah, so I think the steps that I would recommend, or that we recommend people take, are, you'll get the information, you'll talk to the client, you'll make sure you have all their drug list, you'll do the analysis, you'll sort of come up with what your preliminary recommendation is. Do they need to stay in their plan, or is there a better plan? Do you recommend that they change? At that point, you would then talk to your mentor and use that as an opportunity to go over, what your recommendation is, make sure everyone's on the same page, and then call the client back to finalize that recommendation, let them know that this is, our final recommendation. And if it involves a plan change, you could, either do it then with the client on the phone, or set up another time to do the enrollment with the client on the phone. If at all possible, I think it is good to do the enrollment with the client on the phone, sort of do it in real time, because you can just go over the information and just make sure that everything is correct as you're entering it, so that there's no mistakes or hiccups.
Yeah, that's right. In particular, if it's looking like someone needs to change plans, there's usually kind of a back and forth interaction with your mentor. And it's helpful. Andrew mentioned this, and I'll show what it looks like in the tool. But if you send an email with PDFs of the plan details, both for the current plan and of a plan that you're recommending if you're suggesting a switch, so that the mentor can review that to see what information you're looking at, and then follow back up with you to talk through the options. And once you kind of settle on a plan, you'll then have to call the client again to walk through, as Andrew said, the actual enrollment.
And it may be the case that, if the current plan is not good for 2022, you may have like 3 options that look like they might be fine for 2022. Maybe one of them has a very small maybe one of them has a very small monthly premium, but has fewer drug restrictions. Maybe one of them looks like it costs a little bit less, but there might be some more drug restrictions or something else that's concerning. So, I think we've talked about having the current plan and what you recommend, but figuring out what that recommendation is a big part of the conversation that you'll have with your mentor. And you may have 3 or 4 different plans that you're looking at that have pros and cons, and you can talk all those things through with your mentor to come up with, what either is, maybe this really is sort of the standout best recommendation, or maybe it's a situation where there's a couple of different options and they all seem fine, and it's really the client's choice how they proceed. So I don't think I see any other questions in the chat or the Q&A.
I'll go ahead and switch over. And I'm going to review, kind of go through a sample case. We shared a sample intake form in the materials, but I'll share that as well in case folks didn't receive it. And basically just walk through what the analysis looks like on your end as you're doing it and getting the materials. And so this is the Whitman-Walker intake form. Folks who are working with legal aid will get something that looks a little bit different, but will contain all of the same information. And so essentially we try and capture all of the name and demographic information, the Medicare information, the medication list, and then what other benefits they're enrolled in if we have access to that information. For many clients, their medication list either doesn't fit in this box, or they get lists from their provider's office or from their pharmacy. So in many of these, you'll actually get the medications as a separate list. So if you're not seeing something on here, just scroll through the documents that you're receiving from the host organization, because the medication list should be included elsewhere. If you're not seeing a medication list at all, just follow back up with your mentor so that we can double check in our system. In a very limited number of circumstances, a client might not be taking any medications. And so we will still usually do just a very brief analysis. And it's basically just to make sure that folks who are eligible for a low income subsidy and can enroll into a plan that has no premium are actually in one of those plans, so that if medication needs come up, they do have Part D coverage, and they're not entirely without coverage, even if they're not necessarily needing it right now. And so up here, I just included as an example, this client goes by the name Sam Smith, but her legal name, which is what's reflected in the Medicare system, is Samantha Smith Jr. And so if you were making My Medicare account for her or having to enroll her and list her name, you would want to make sure that for last name, you include Smith Jr. so that that matches exactly what's in the Medicare system. And then I just wanted to make sure, I'm not sure if we mentioned this earlier, but folks will also receive from their host organization a guide about making the My Medicare plan with some suggested templates for username and password that we suggest. And so you'll get that information from Legal Aid or Whitman Walker as you're working with us with additional details if you do have to create a My Medicare account.
Hey, Erica, I'm sorry to interrupt. We had a quick question asking if you can just drag it a little bit more to the center. I think the left portion of the form maybe.
Yeah. That
looks better.
Okay. And I'm actually just showing this kind of as a guide, and then I'll go through it a little bit, but we'll primarily be working on through the My Medicare website. So I'll go back and forth a little bit, and then I'm actually going to close that document. But just so folks can see, when you first get on Medicare.gov, this page will change tomorrow from preview 2022 to you can actually enroll in 2022 plans, since tomorrow is when open enrollment actually starts. So for Sam, if we had her log in, we would navigate through this page. But I tried to log in, we couldn't get into Sam's account. So we're just going to go ahead and do a generalized search for her. And so it will automatically default to showing you 2022 plan options for folks. And so as we walked through earlier, we're looking at Sam's Part D drug plan coverage. And then for her zip code, I'll want to enter exactly what's in the address field. And so I will enter the 20019. And then it asks if Sam gets help from any of these assistance programs. And so on her form, I see that the host organization has checked that she has Medicaid and QMB. And so I'll check the box saying that she has Medicaid. And then this question asks if you want to see drug costs when you compare plans. You're almost always going to answer yes to this question because that's the main reason you're doing the analysis. It's to compare the drug costs. The only situation in which I will check no kind of ties into one of the questions that was asked. If you're having to do a generalized search, one of the downsides is that it doesn't save your list of medications. So if the system times out or you have to exit to talk to the client about the analysis that you did, when you go back in, you won't be able to pull up that list of medications again. If you've saved all the printouts and say you decide that Sam needs to switch from AARP to Humana, you can't get your mentor or Sam, get in touch with them to talk through that with them. So you save all the information, you do that review, and you decide, okay, Sam does actually need to change plans, and I already know what plan she needs to be in, so I don't need to re-enter the information again. If you click no, you can then kind of skip to just the list of plans, and I'll show you all what that looks like. But for the most part, we should be checking yes to this box because that's kind of the main point of what we're doing here for folks. And then you will be taken to a screen to add prescription drugs. If you're doing the personalized search, you will sometimes actually see a list of medications automatically populate here. And so I will then pull from the intake form, and you may not be able to see the intake form, but I'll be entering on here from Sam's list of medications. And so as you start typing, you'll see that a box will pull up on the bottom that will start trying to autofill. And so once you see the medication, you can click on it. It's important, as Andrew mentioned, to pay attention. I don't have any examples in this intake, but if a client has a very long medication name, make sure that you're matching exactly what they're taking. There's sometimes slight variations in like the letters at the end, or if someone is taking a medication or two medications that are combined, you want to make sure that you're selecting, for example, acetaminophen dash oxycodone and not just acetaminophen if someone is taking the combined version. But this dropdown is very helpful because it does auto-populate pretty well with basically all of the medications that are in the Medicare system. And then when you click add drug, this will usually come up with whatever the standard dosage and quantity is for a medication. So you'll compare that to what's on the list. For some medications, there's only one dosage, so it's pretty easy. And then you click add to my drug list. And then you will continue doing that for all of the medications that are on somebody's list. And then if somebody has listed the name brand of the medication and there's a generic available, you'll get a pop-up that says a generic is available that's a lower cost version. We will usually select to add generic and do the analysis with the generic version. And then once you've done it, you can double check with the client. In most cases, the plans will not cover a name brand version if a generic is available. So most clients are taking the generic version of a medication. Clients often don't realize that they're taking the generic version because their doctor may be telling them the name brand, but at the pharmacy, it's usually substituted for the generic. And as I mentioned, most of the plans won't cover the name brand. So if you enter a name brand, when you get to the plan analysis, you'll see very, very high costs. If you have a client who tells you that for some reason they need to take the name brand and they cannot take the generic because they've had some issue or interaction or complication with it, you can try and do the analysis with the name brand. If it's showing up as very high costs and not covered by any of the plans, and I'll show some examples of this, go ahead and put in the generic. And this is what Andrew was mentioning, that if something's coming up as not covered or really high cost, include the alternative. So include the generic. And then generally the client would then have to work with their doctor to get an exception to get that name brand covered. And then there was a question about whether it might ever happen that there's no option for the correct dosage. So a client's taking a dosage that's not on the list. The plan finder is actually usually incredibly accurate. So it's more common that a client has listed an incorrect dosage on their list than that the plan finder is missing something. So usually what I'll do if something's not coming up is I'll double check with the client and have them, often like pull up their actual prescription bottle and look at that and see what that shows. The other thing that will sometimes happen is a medication list may list 20 milligrams and you search and there's no 20 milligram available, but 10 milligram is. And so it's likely that's what's actually happening is the client's taking 2 10 milligram pills per day. So usually we don't run into options though, with dosages not showing up. Oh, I hit next too soon. And this quantity is helpful more as a guide for you when you're doing the plan analysis. The quantity itself doesn't really impact the costs or what shows up as the coverage. There's a different thing that we look at to make sure that the quantity that somebody's taking will actually work for them. And then I included this inhaler, which is an albuterol inhaler, because we've started to see it with a lot of our clients who are prescribed a standard albuterol inhaler. There's two name brand versions of that, Pro Air and Ventolin. It's one of the few exceptions where the plans actually don't show up as covering the generic albuterol, but instead they all show up as covering Ventolin. Those are equivalent for patients, and the pharmacy will actually substitute one if something else is not covered. So for the analysis, we'll usually enter Ventolin. And if you have any questions about that, if it's coming up with one of your clients, just double check with your mentor. And you'll get there's one of the documents that's included is the excluded drugs. And then this is also in some of the materials as well, so you can refer back to it. And so once I've double checked and I have my completed drug list, I would select done adding drugs. And then you're taken to a screen where you can choose pharmacies, and you have the option to choose up to 5 pharmacies. Most clients will only list one. Occasionally clients will go to a couple different pharmacies. They may pick up some medications at one place and others somewhere else. For folks who are using CVS, we try and encourage them to give us the location. If you don't have that, to at least start on doing the analysis, you can pick the location that shows up that's closest to their zip code, and then you can double check with the client afterwards. Generally, if one CVS is in network, they're all going to kind of offer the same coverage regardless of which CVS you go to. And then this client also goes to Whitman Walker. So if you know the zip code of a pharmacy, it can be helpful to change that up here to navigate to a more accurate list, or you can also try entering the name of the pharmacy, and it will usually pull it up. If you're not finding it by name, I would try and search and do by zip code, because generally all of the pharmacies that people go to are in this system. There's an option to select a mail order pharmacy. We generally don't recommend that to folks because it can cause confusion. If a mailing gets lost, it can be hard to replace those medications. Oftentimes clients have to be home to sign for something, so it can be more challenging. So we generally recommend and see that most of our clients are using local pharmacies, and many of those pharmacies now offer their own delivery option that is different than mail order. So if a client tells you that they use Whitman Walker, but they bring the prescriptions to my house, you would still want to select Whitman Walker pharmacy. That's not mail order, and that it's not going through the Part D plan mail order. And so you then, once you've entered all of that information, you're in the plan finder tool. Andrew, does this look okay on your end? I just want to make sure.
Yes. Yeah, okay. I see it fine.
Perfect. So there's different, so if you're in a personalized search, usually the plan that somebody is in will show up at the top. Since we're doing a general search, on their intake form, I saw that Sam is enrolled into SilverScript Choice. So usually I would want to navigate to SilverScript first to check what that coverage looks like. And so if you sort plans by lowest drug and premium cost, it will pull up plans kind of in the order of their yearly drug cost. If you sort by lowest monthly premium, then it'll pull all of the 0 premium plans to the top. And so I'm scrolling down and I'm not seeing SilverScript, but I know that it's a 0 premium plan. So I'm going to sort by that option. And I'm also seeing, as I'm looking, that all of these plans seem to have very, very high costs in the thousands of dollars. And so when I go in and I see something like this, it's an indicator to me that there may be an issue with one of the medications and not necessarily an issue with a particular plan. And so if I click on the plan details for SilverScript, and you scroll down, you see it does have no monthly premium. And then if you go to this drug coverage, this shows you the costs of the medications. And so I see that there's 2 medications here that are showing up as very high cost. If you scroll down, and they've added some additional information into this page that's not as helpful as what was in years past, so you do have to do quite a bit of scrolling. But if you click on view more drug coverage and you scroll, you see this box that tells you the tier, which is kind of the cost level that something's at. And it also reflects that 2 of these medications are not covered. And so I see that there's an issue with SilverScript. And so I would go back. And what I also saw, though, is that many of the plans have very high costs. And so I would look at what's considered the lowest cost option, which is Humana, and again, scroll down to the drug coverage field. And so I'm again seeing that this benzonatate, which is Tesla and Pearls, is not covered. So if you're in a situation like that, it's an indicator that maybe this is an excluded drug. And so this is actually a cough medicine. So patients are often prescribed this for cough, even if it's prescribed by a doctor, as Andrew was mentioning, it's considered over the counter. And so I just included that because if you run into a situation like this where it's like, wait, everything is thousands of dollars, it might be that it's an excluded drug. And so what you actually want to do is just take it off the list entirely because it's going to skew your results otherwise. We included a handout in the materials that you received that lists excluded drugs. You can also usually just take the drug name and put Medicare after it in a Google search, and you will often pull up a website that will tell you that a medication is not typically covered by Medicare. And then you know to just exclude that from the search. And so you can use the back buttons and just remove that drug. And then if you click done, and you'll see that your pharmacies are still in there. And then again, it'll pull up all of the plans. And so this pulls up every Part D plan that's available in this client zip code, including ones that are not eligible for the low income subsidy. And so sorting by lowest monthly premium, I see Humana is still the lowest cost, but is much less expensive than it was previously. And similar, there's many plans now that are lower cost. However, SilverScript Choice, which is the plan that Sam was enrolled in, is still around $6,000. And so I would click on the plan details and click drug coverage. And in scrolling down, I would see that Repatha, which Sam is prescribed, appears to not be covered. Usually if something is very, very high cost like this, it means it's not covered, but it's still worthwhile to go down to this view more drug coverage option and just confirm that here something is showing is not covered. And so it seems like for Sam, this plan is probably not a good option for her next year, and she may want to consider a change. And so I would go back to the search results. And generally, especially if you're in the personalized search, it's usually easiest to sort by the lowest drug and premium costs, because that'll combine all of those costs for folks and sort plans by basically what somebody will be paying out of pocket. It's important to note that it's a yearly drug cost. So this is the total that somebody will pay over the year. And so as you scroll, you may see that there's slight differences in these costs. But as you're comparing, just keep in mind that this is a difference of $10 or $11, and that's over the year. And this is an estimate. So that comes out to about $1 a month or so. And so say that Sam had actually been enrolled in Clear Spring, that's $146. And you see that Humana is about $10 cheaper. It's usually not worth recommending a change unless there's some other issue with that plan, because over the course of a year, that dollar may not actually be what's reflected at the pharmacy, since it is an estimate, And as Andrew was mentioning, many of our clients, once they're in a plan, they prefer to stay in it, and it can be more disruptive for them to have to make a change to something else and worry about getting a new card, maybe having to deal with a new plan if they have questions. And so usually we recommend, if there's a difference of less than about $20 to $25 or so over the year, that's generally not a reason on its own for somebody to change plans. But here, where Sam has to change anyway because her current plan is not working, I'm going to take a look at the lowest cost option. There is this add to compare tool. It was more helpful in the past. It doesn't include really any of the major information. I'll show folks what it looks like. So it can be helpful kind of as a starting point if you want to figure out what the problem is with a plan, because it'll tell you how many drugs are covered versus not covered, and if all of the pharmacies are in network, but it doesn't include any of the plan detail information. So you'll still have to ultimately have to go into those plan details to do the full analysis for the case. And I was just double checking to make sure there weren't any questions. And so I'm now basically doing a review to see if I should recommend to Sam that she enroll into Humana Basic. And so I see that her cost would be about $135 over the year. There's no monthly premium. And then if I go to the drug coverage, I see that both of her pharmacies are in network. It's important if someone uses two pharmacies that you check here and make sure that they're both in network. If one pharmacy is in network and another is out of network, the overall costs that are reflected will usually still be low because they'll just reflect the costs of the in-network pharmacy. And you'll have to navigate to a different portion of the screen to see that issue with the out-of-network pharmacy. If a client is in a plan that's showing as out of network for their pharmacy, it's usually best to just check in with them. Sometimes clients would rather switch pharmacies rather than switching plans. Other times, clients have had a relationship with their pharmacy and they want to make sure that they can continue to go there. So they would elect to switch plans and choose something that remains in network for that pharmacy. And this is really important because if a pharmacy is out of network, the medications will not be covered there at all. So it's not that someone will pay a little bit more or slightly higher costs. They will just have no coverage. The other thing you will sometimes see that's not here is some pharmacies are considered preferred in network. And so it might reflect slightly lower costs. Again, these are all estimates. So it's not necessarily exactly what somebody's it's a pretty good estimate, but it might vary slightly. We don't usually try and find a preferred pharmacy, but if you're finding a plan that's preferred at somebody's pharmacy versus one that's not, then that might be a reason to pick that plan. And so again, this is showing the yearly costs for each of the medications. And then this gives you a month by month breakdown of what this person will pay. And so over the year, they would pay $137. And then month by month at the two pharmacies, in the first few months of the year, they would pay between $32 and $36. For clients who are on more expensive medications, you'll see that after a certain number of months, their costs will usually go down to zero. And that's that catastrophic coverage that Andrew mentioned. So after a certain amount has been spent on medications, somebody's costs will go down to zero. And that includes the costs that are being subsidized by that low income subsidy. So Andrew mentioned that amount of around $7,000. That doesn't mean that the client themselves is paying $7,000 out of their own pocket. They're paying those $1 to $9 copays, and then LIS is picking up some of that. And so once that combined copay cost has reached that limit, then their costs will go down to zero. This is important too, because many of our clients, especially at Whitman Walker, are on HIV medications that are very expensive. And so they'll be experiencing those $0 copays toward the end of the year. And so sometimes when you'll call somebody and let them know what their estimated costs are, they're thinking about what they've been paying this month and last month at the pharmacy, which was zero. And so when you tell them that they have to pay $32, that's going to sound like a lot of money for them. And so usually if you just remind folks that, oh, remember it resets at the beginning of the year and you usually have to pay a little bit and then those costs go back down. And so I'm seeing as I scroll down and click view more drug coverage, you can kind of skip through these boxes. This basically just walks through what Andrew reviewed that are just the general costs, but isn't particular to a person's medications. And so it's this box that's important and that we want to review for all of our clients, because this shows any drug restrictions that the person might have under this plan. And so the three types of restrictions are prior authorization, quantity limits, and step therapy. And so prior authorization means that somebody has to get prior authorization before the Part D plan will cover that medication. It's usually a relatively straightforward process that's handled between the pharmacy and the physician, where the physician has to fill out a form or call the Part D plan to basically explain why they're prescribing that particular medication, or that the patient meets whatever criteria is set by the Part D plan to cover the medication. There can sometimes be challenges for folks depending on the reasoning behind the prior authorization, and usually they'll work with their doctor to navigate that. Quantity limits are kind of exactly what they sound like. The Part D plans will often set a limit on how many of a certain medication someone can fill, usually on a monthly basis. And so if you see yes anywhere and you click on it, it'll pop up this box that tells you what the quantity limit is for that particular drug. Usually the quantity limit is established by the typical prescribing for that medication. So in most cases, our clients are at or under the quantity limit, and it's not an issue. So if somebody is at the quantity limit, that's totally fine. It's not a reason to be concerned. The only reason to be concerned or have a red flag that maybe a plan won't work is if somebody is over the quantity limit. So if they're needing to take more pills per month than what's allowed by the plan. And so you'll want to make sure and just click through all of these quantity limits and just make sure that all of these match what's on the intake form. I'm not going to compare between the two, but usually you'll just want to have those two things side by side, and just making sure that any of these limits are under what the plan recommends. This one is an injector, and so it'll sometimes look a little different, but you'll see on the intake form that Sam gets 2 injectors a month, and what the plan covers is 3 2-packs a month. So Sam only uses 2 of the auto injectors, so she is under this quantity limit. And then similarly with the inhalers, folks, you can check with folks. Usually they're using one inhaler a month. This covers 36, so the client should be totally fine. But you can always double check with them, especially if there's a lot of quantity limits, or if a patient is taking a medication several times a day. It can be worth just verifying with them that what they listed on the form is correct, so they don't run into an issue with a quantity limit. Step therapy requirements are the most restrictive, and usually what they require is that a patient have tried a different medication before the Part D plan will authorize the current medication that's being prescribed to them. So there's usually some series of alternate medications that the plan has identified. And so basically you have to work through the steps before they'll approve your current medication. If somebody is already in a Part D plan and you see a step therapy requirement, it's generally not a concern, because if they've been taking that medication, it means they've already overcome the step therapy or the prior authorization requirement. But if you're comparing options to try and decide what plan to enroll somebody in, if one of them has a step therapy requirement and another one doesn't, that could be a reason to pick the one that doesn't, because it means that it'll probably be easier for the client to get all of their medications without having to work with their doctor or potentially take a different medication. Unfortunately, if there's a step therapy requirement, this will just say yes. It won't really include any information about what that requirement is. If there's a client who's having to enroll in a plan with this restriction and they have some concerns, you can usually search through the plan's website, and you can often find information if you need to about what that requirement is. And sometimes you'll find that the client will have met that requirement anyway. Usually with step therapy, if I tell the client, oh, all of the plans require that you have tried X medication before they'll prescribe Y medication, often I'll find clients say, oh, I tried X medication, it didn't work for me. My doctor said this is the only one that will work for me. And so their doctor will have to jump through some hoops, but they'll still be able to get their medication. And so for Sam, kind of all of this looks good except for this prior authorization requirement. As I mentioned, those are usually relatively straightforward. Since there was another plan that was relatively low cost, you could go back and compare the two. So Humana Walmart is also relatively low in cost. It does have a very, very small premium. So since it's basically the same as ClearSpring Health Value, if choosing between the two, you want to default to choosing the 0 premium plan, even though 60 cents isn't very much money. It's an additional thing that the client has to worry about, and they would either be getting billed for that 60 cents or have it come out of their Social Security check. And so just to make sure I'm kind of covering all my options, I would scroll through this next lowest cost plan and just check. The only thing that seemed like it might potentially be a hurdle was that prior authorization. And so as I scroll down, I see that this plan also has a prior authorization requirement for Repatha. And so since these plans are otherwise basically equivalent, I would save as a PDF that other list of plan details. And on most browsers, you can do that by printing, and then you'll have generally an option to save as a PDF depending on what browser and your laptop. And so you want to save this very long document of the plan that you're recommending and email that to your mentor. And then I also would have wanted to save the SilverScript choice, that same plan details page for SilverScript, because that's the plan that Sam is currently in. And I would send both of those documents to my mentor so that they could review and just double check that those options make sense for the client. And so now that I've decided that I want to enroll Sam into Humana, after tomorrow, you'll see an additional box on this page that says enroll. There are many, many steps you have to go through, and I'll walk through those, and they're in the last few pages of the online protocol document that we shared. But there are many steps you have to go through before you actually enroll the client. So folks, especially at the beginning, are always a little bit nervous to go on Medicare.gov, especially if you're doing the personalized search, because they don't want to mess a client up or inadvertently make a change. Essentially, making changes to the plan list, even in a personalized search, will have no impact on a client's actual coverage. And even once you click enroll, there's 4 or 5 screens you have to navigate through before confirming that enrollment. So feel free to click just to see what that looks like, especially when you're getting started. And as I mentioned, there's many, many confirmation screens that you have to click. And I'll show what those look like before somebody would actually be enrolled. As Andrew mentioned, say Sam had been enrolled in Humana Basic, I reviewed it, it looks like it's still a good option for her. There's nothing that you need to do then. She will automatically remain in that plan for next year. And so I don't need to click enroll. I would still save the plan details to email them to my mentor, and I would call Sam and let her know that Humana is still a good option for her. I would ask her if she wants a copy of the plan details with the estimate. Many clients let you know that they don't want it because they've kind of been paying the same thing, so they have an idea of what their costs are. And so send it to your mentor, but you don't need to send it to the client. And you'll receive additional information from your host organization about any additional documents that we may ask you to send to the client. And then I'm going to bring up the online protocol document. And so, as I mentioned in the last pages of this document, it shows you what the enrollment screens look like. And so it's pretty straightforward. You have to enter personal information about the client. And as I mentioned, you should make sure that things are matching exactly. The middle initial is not required. So if someone doesn't include it, you can just skip it. And then it'll tell you the plan that you're joining. So you want to double check and make sure that you've clicked enroll on the correct plan and that that matches what you talked with the client about. There's a series of questions on this step. The only one that's required is the question about whether you have other drug coverage. For pretty much all of our clients, the answer to this will be no. And because this is talking about other coverage that might be primary to Medicare. So that would primarily only be folks who maybe have employer-based coverage and just want a Part D plan as secondary. It does not include, for example, if somebody has Medicaid and that Medicaid is maybe picking up some of the Medicare excluded drugs, that's not covered by this question. So you generally should just select no here unless you have a very, very specific situation, and that would be flagged by your host organization, by your mentor up front. But I don't think that I've ever clicked yes on this question in my 7 years or almost 8 years of doing this. Similarly, ADAP, which is the AIDS Drug Assistance Program that we mentioned, offers copay coverage for folks who are HIV positive. So that acts as secondary coverage. So that's not covered by this question also. And then all of the other questions on this page are optional, so you can generally skip them. There are a couple of questions toward the bottom, so it didn't make it onto the screenshot, that ask about a language preference. And so if you're on the phone with a client and they have one of those preferences, if they're a Spanish speaker, you could check that box, but otherwise we generally just skip through all of those optional questions. And then there's a screen about paying your plan premium. So the majority of our clients don't have a premium. Their premium will be zero. And so we will still select this box that says, I want the plan to bill me each month. And so that person should then not get a bill because their premium is zero. But what it does is if some sort of issue comes up and maybe their extra help or low income subsidy is not being captured correctly in the system, or there's some sort of glitch, then they would get a bill in the mail, and that should trigger them to call Whitman Walker or legal aid or the plan to say, hey, like, I'm supposed to have a zero premium plan, but I got this bill. Can you explain what's going on? If you select deduct it from my Social Security benefits and that person incorrectly starts being billed for premiums, those premiums are automatically gonna come out of their benefits. And then they're potentially having to wait longer for reimbursement, and you're having to kind of deal with both Social Security and the Part D plan to get things fixed. So it can be more challenging. If you have a client who isn't eligible for a zero premium plan, or for some reason is choosing to enroll into a plan that has a premium, maybe that's the only plan that worked for them was one that had a small premium, then you would just want to check with them on which of these two options they prefer. And I would say it's generally better if folks are okay with navigating those monthly bills to get the bill in the mail, because you can then catch if there are any issues. But if someone's comfortable with what the premiums are going to be and they just don't want to deal with that bill, then they can't have it deducted from Social Security. If someone does that, it's usually helpful to just note that if they get a bill in the mail, they should make sure and check in with the Part D plan to see if they should pay that, because there sometimes is a delay in the premiums being deducted from the Social Security benefit. And then on this last screen, and you can disregard this arrow, I think that inadvertently ended up in there from moving some things around. But you can this is essentially confirming that the client is agreeing to enroll into the plan, and that there'll be some exchange of information that happens between Medicare and the Part D plan. And that Part D coverage isn't offered outside the country, which is typical. And so you want to agree to those statements, and then we select the option that you're the person joining the plan or that you're helping the person join the plan, because you're simply helping them with the enrollment. This second option is for folks who are, for example, brokers or have some other authority to enroll that person in the plan. But for all of our clients, we're just helping the person join the plan. So we'll select this option up here. And then once you click next on this screen, you'll confirm the enrollment, and that will bring you to a screen with an enrollment confirmation. You'll want to save that as a PDF and send that to your mentor. We also send that enrollment confirmation to the client. It usually includes a confirmation number and information about the plan that they're enrolling in. And that way, if for some reason the client doesn't get information in the mail, they can follow up with the plan directly. And we just have proof of having done that enrollment. So that's everything that I was going to review on the Plan Finder tool. I'm just going to double check if there were any questions. So I see there was one question. So all other things being equal, do we recommend the least expensive option and or ask the client to choose between equivalent plans? So we will usually just recommend the least expensive option if as you said, everything else is equal. You can, if there are two plans that are exactly the same, you can ask the client if they have some preference between the two. In most cases, our clients just want the least expensive option and something that they know will cover everything. In a small number of cases, a client may have been enrolled in a particular plan in the past and had some issue with it. And so they might say, oh, I don't want SilverScript, like they caused all these problems for me. And so if there's then an equivalent plan, you can enroll them in that option instead. But generally, we just try and kind of narrow the options for the client if everything else is the same and just recommend that least expensive option to them.
And there's another question in the Q&A to confirm, does the mentor or host organization send copy of enrollment to client, or do we? So I think it's true for Walker, but at Legal Aid, the closing letter comes from the volunteer attorney, and the enrollment confirmation is an attachment that goes with that closing letter. So we have model closing letters that we'll send that you can use to make sure you're including all the correct information in that closing letter and the correct attachments in that closing letter. You will send a copy of the closing letter and the enrollment confirmation and the other information to your mentor. But since the volunteer attorney is the one providing the assistance to the client, that will also come directly from the volunteer attorney to the client.
That's right. We do the same. We had a small subset of folks last year who were volunteers who were entirely remote last year, and clients didn't have access to email and so wanted things by mail. And so we did work with a few people to help navigate that challenge, but many more of our clients are on email now and prefer to receive things that way. So we similarly encourage the volunteer to be the one to send that information to the client. And those forms include contact information for the host organization if people have questions in the future. And then this slide just gives a very brief overview of next steps. So folks have already signed up for one or both of our host organizations. And so depending on who you signed up with, you should be receiving an email within the next few days from one of the folks, from either Lee or from Sylvia, with information about when you'll start receiving cases. For Whitman Walker, we'll have a few additional questions. We place cases as we did for last year, in kind of 2-week batches. And so we'll ask folks to let us know what their preference is on that. I think for legal aid, but correct me if I'm wrong, Andrew, Sylvia will send out information and you kind of place cases on an ongoing basis. Open enrollment runs until, as we've said, December 7th, and we all get a very large volume of cases, and we really rely and couldn't do this work without all of you. So we really, really appreciate it. If anything comes up and you're not able to connect with the client, or something changes with your schedule and you're not able to take any of the cases that you're handling, please just reach out to our mentor. We're happy to work with folks. We know that things continue to be challenging in this like weird world that we're all living in. But our clients are really, really appreciative of this work and are always really happy to hear from folks. And then we'll also, in those materials you get, we'll include a link to the recording. And if you have any colleagues who signed up, but for some reason weren't able to attend today and are asking about the recording, we'll be pushing that information out as well. Sylvia, did I miss anything?
No, I think you covered it all, Erica. I think that the key thing is simply to keep in mind that for folks, when you signed up when you registered for the training, you had indicated which organization you wanted to volunteer with, and whether it is legal aid, whether it's Whitman Walker, or both of us, you'll be hearing from us likely by tomorrow with sort of preliminary steps. And at least in the case of legal aid, we'll be sharing our assignments early next week with which clients you'll be having. For newer folks who have not previously done Medicare Part D enrollments before, we generally refer only 2 clients to each attorney. And for those who are more seasoned, we provide additional clients. If there at any point your availability changes, the key is to simply communicate with us. As Erica pointed out, both organizations rely greatly on our volunteers. And the sooner we can know about these changes, all the better.
Yeah, definitely. And we will, at Whitman Walker, we'll usually place between 3 to 5 cases with folks. And similarly, we appreciate anyone who has more time or wants to take more cases. This is a really good opportunity to connect with clients and just give them information that they are very appreciative of. So feel free to, connect with Sylvia or Lee as you have additional availability. And then I think there was just a question I'll answer quickly in the chat about if somebody's not DC barred, folks can still send those takeaway or closing letters. And if you have any questions or concerns around where you're barred, you can reply to that email that you'll get and we can navigate that with folks. But thank you very much to everyone for being here. We're really looking forward to working with you all.
Thank you very much for participating and volunteering. We are also looking forward to working with everyone.